Hello, I hope you are having a great day. I have separated out this information on inhalation drugs to make covering asthma and COPD easier. I hope that you find this helpful. This is also a pretty long presentation. Under required readings on Blackboard for COPD, you will find a list of common prefixes, words, and suffixes. I have put the suffixes that pertain to this module on this slide. Knowing these will help you determine the drug class of that compound. Inhalation drug therapy has three obvious advantages. The therapeutic effects are enhanced when they are directly administered to the desired tissue. Systemic effects are minimized in the same way. And by delivering the drug to the tissues, it relieves acute attacks faster.
A nebulizer is a small machine that turns a liquid medication into a mist to breathe into the lungs. Nebulizers and inhalers both work well to deliver medicines to lungs. Nebulizers may be easier to use for older persons, babies and young children, or anyone who has trouble using inhalers. They are less expensive but have fewer selection of drugs available for nebulization. The cost of the machine is between $25 and $50 and is covered by insurance. The unit dose vials are pennies apiece. The nebulization process takes 5 to 20 minutes. Please see the patient education handout provided to you from prescriber's letter on nebulizers. There are multiple types of inhalers. The patients need to be taught how to use each specific type of inhaler prescribed to them. Multi-dose inhalers and Respimat are ordered by the inhaler and not the number of actuations in the canister or the number of actuations needed each month. It is better to use the term inhalations rather than puffs. Dry powder inhalers are dispensed by the inhaler, while hand inhalers are dispensed by capsules. Inhalers are much more expensive and can be into the $300 to $500 range for one inhaler. They are more convenient and portable. There's also a wider selection of drugs and a multitude of combinations to meet patient needs.
As a practitioner, you must match the inhaler to the patient. Simpler is better. At each visit, their inhaler technique needs to be assessed. Inhalation therapy is most often used for patients with COPD and asthma. But there are other indications such as pulmonary hypertension, HIV patients, and cystic fibrosis and bronchiectasis patients. Although bronchodilators improve emptying of the lungs and increase exercise performance, these changes do not correlate with improvements in the FEV1. The FEV1 is the forced expiratory volume in 1 second and is measured by spirometry. Bronchodilators are agents which are the foundation for symptomatic management, although they do not modify the decline in function in COPD or the changes in the structural cells in asthma. Here are the short-acting beta agonists that are used. Short-acting beta-2 agonists are considered rescue inhalers for rapid improvement of symptoms and are used to relieve asthma attacks or sudden breathing problems. They provide temporary relief of symptoms such as wheezing, coughing, chest tightness, and other breathing difficulties. They are also used before exercise to prevent breathing problems. Within minutes after inhalation, these medications quickly open the airways to make breathing easier. The most common rescue inhaler medicines in the U.S. are listed on this table. The dose of the short-acting beta agonists may be doubled for mild exacerbation. HFA stands for hydrofluoroalkane, which is the propellant in the inhaler. A long-acting bronchodilator is preferred to regular use of short-acting bronchodilators. Overuse of short-acting beta-2 agonists can lead to desensitization, I said that wrong, desensitization, greater number of exacerbations, and even death. Note that these agents are also available as nebulizer solutions, which may be less expensive but may be more inconvenient to use. Level albuterol has not been proven more effective than albuterol. I tend to use ProAir HFA or Ventolin HFA. Both of these have a dose counter. ProAir, though, is now generic. It was costing $60 as a non-generic, and as generic it's about $30. Short-acting anticholinergic agents are available as metered dose inhalers or a solution for nebulization, both alone and in combination with albuterol. The combination of beta-2 agonists with an anticholinergic can be used to improve efficacy and/or limit adverse effects. Short-acting bronchodilators must be included in the pharmacologic regimen for all patients with COPD and asthma, and used as needed for symptom relief. Albuterol or ipratropium can be used as they have similar efficacy. Ipratropium may be preferred due to its longer duration of action. It's 6 to 8 hours versus 4 to 6 hours for albuterol. However, combination therapy with albuterol plus ipratropium provides slightly better bronchodilation than either agent alone and should be considered when the use of albuterol has failed to provide adequate relief of symptoms. Even if used in a scheduled regimen, these can still be used as needed for relief of symptoms.
Maintenance or controller inhalers containing long-acting bronchodilators and corticosteroids to control asthma and COPD. They are typically used once or twice daily, even in the absence of breathing problems. These medicines open the airways and reduce swelling for at least 12 hours. They are taken every day to control chronic breathing problems. Long-acting beta agonists are not appropriate as asthma monotherapy. They can be used in combination with an inhaled corticosteroid. Long-acting beta agonists and long-acting muscarinic antagonists are first-line options for COPD patients with persistent symptoms despite use of a short-acting bronchodilator. Therapy can start with 1 or 2 long-acting bronchodilators, depending on the severity of symptoms and exacerbations. You can add a LAMA to a LABA or vice versa if one does not control symptoms. Arformoterol, indecaterol, and oloterol are long-acting beta agonists approved for use in COPD and not asthma. Formoterol is a long-acting beta-2 agonist, but because it has a fast onset of action, it can also be used as a rescue medication. Formoterol has an onset of action within 3 minutes and peaks in 15 minutes, but its action can be up to 12 hours. Formoterol by itself is available only in solution forms for nebulizing. In combination with a steroid or a long-acting muscarinic antagonist, it is available as an inhaler. Salmeterol has a delayed 10 to 15 minute onset of action, but the duration of 12 to 18 hours versus 3 to 6 hours for albuterol. Formoterol has a similar onset of action to short-acting bronchodilators. LAMAs are not indicated for asthma as monotherapy. They are for COPD. The use of a LAMA, specifically tiotropium, is used as add-on therapy for patients with asthma who remain uncontrolled despite the use of inhaled corticosteroids and long-acting beta agonist treatments. Tiotropium is included in the Global Initiative for Asthma Strategy document as an add-on therapy for patients at step 4 or 5 with a history of asthma exacerbation. Now for COPD, LAMAs are superior to LABAs in preventing exacerbations and possibly hospitalizations, so it may be preferred in patients with 2 or more exacerbations or at least 1 hospitalization in the last year.
Okay, the combination of a LABA-LAMA. These are used for COPD only, not asthma. For COPD, the first-line option for patients with persistent symptoms despite use of a short-acting bronchodilator is this combination. Therapy can start with 1 or 2 long-acting bronchodilators, depending on the severity and the number of exacerbations. Add a LAMA to a LABA or vice versa if one does not control symptoms. LAMAs, actually, the muscarinic agents, are superior to LABAs in preventing exacerbations and possibly hospitalizations, so it may be preferred in patients with 2 or more exacerbations or at least 1 hospitalization in the last year. So remember, LAMAs are preferred over LABAs for COPD, especially with 2 or more exacerbations or a hospitalization in the last year. When using any long-acting bronchodilator, it's essential that all patients be provided with a short-acting bronchodilator for relief of symptoms. Long-acting agents are given once or twice daily, whereas the short-acting agents can be given up to every 6 hours as needed. Although there has been data indicating an increased risk of asthma-related deaths in patients taking long-acting beta-2 agonists, this risk has not been identified with COPD. So to make a long story short, there's been a large study, and what it found was that the risk of death and hospitalization was associated only when patients took the beta-2 agonists, the long-acting ones, without the concomitant use of corticosteroids. And it was most common, the deaths and problems were most common in the younger populations, age 4 to 11 years, and in African American patients. So based on this huge data study, long-acting beta agonists should not be used without corticosteroids in patients with asthma. However, these risks are not associated with long-acting beta agonists use in patients with COPD. Now, despite differences in pharmacokinetics, there are no known differences in efficacy between salmeterol and formoterol, or formoterol and aformoterol, which are solutions for nebulization. In patients taking long-acting beta agonists, short-acting anticholinergic agents, or short-acting beta-2 agonists can be used for relief of symptoms as needed.
In patients with COPD that are taking long-acting anticholinergic agents or LAMA, such as tiotropium, a short-acting beta-2 agonist or SABA is recommended for acute relief of symptoms. Some investigators have expressed concern that patients taking tiotropium might have a reduced effect when using short-acting ipratropium for relief of symptoms due to slower dissociation from muscarinic receptors versus tiotropium. When studied in COPD patients, patients receiving tiotropium with ipratropium provided some acute increase in FEV1. However, the improvement in FEV1 was greater in patients receiving a short-acting beta-2 agonist. Although there wasn't any evidence of adverse effects with combination short and long-acting anticholinergic therapy, there isn't any reason to recommend this combination. So the use of tiotropium with other anticholinergic agents is not recommended. Okay, for long-acting anticholinergics or long-acting muscarinic antagonists. Okay, tiotropium is a once-daily long-acting anticholinergic agent, and it's delivered by a dry powder inhaler or DPI. It blocks the effects of acetylcholine on M3 receptors, and that results in respiratory tract smooth muscle relaxation and reduced mucosa secretion. Similar to other bronchodilators, tiotropium has not been found to improve FEV1 or reduce mortality in patients with COPD. Overall, however, there's insufficient evidence to recommend one long-acting bronchodilator over others, so whether it be a LAMA or a LABA in COPD. And that recommendation is really only for initial therapy, so that the information I just gave you contrasts with evidence from studies on COPD patients who have had 2 or more exacerbations or at least one hospitalization in the last year. So in those patients, and these are hospitalizations with COPD, and in those patients, LAMAs are superior to LABAs in preventing exacerbations and possible hospitalizations. So they may be preferred in patients with history of exacerbations. Now, tiotropium is an add-on for asthma in Step 4 and Step 5 of the GINA guidelines.
Beta-2 agonists may produce a resting tachycardia and precipitate arrhythmias, palpitations in susceptible patients. There can also be tremors or cramping and insomnia with them. Hypokalemia can be especially common when patients are also taking thiazide and loop diuretics with a beta-2 agonist. Anticholinergic agents have mild side effects, mainly dry mouth and sometimes taste disturbances. Long-acting agents have a similar adverse effect profile and do not demonstrate improved tolerability over short-acting agents.
Okay, inhaled corticosteroids monotherapy is only FDA approved for treatment of asthma and not COPD. Most are dosed at 2 inhalations twice daily. Most come in 2 strengths with usually double the micrograms per actuation. They are given in ranges of low, medium, and high as indicated on your handout.
All of these are approved for COPD and asthma, except for the Advair HFA. They are 1 or 2 inhalations twice a day. Remember for asthma that a long-acting beta agonist must be in combination with an inhaled corticosteroid and not used alone. Advair Diskus is now generic but still not cheap. It's around $160 as a generic.
Okay, a combination inhaled corticosteroid, long-acting muscarinic antagonist, and long-acting beta agonist, or triple therapy as we like to call it. These should be considered for patients with severe or very severe COPD with continued exacerbations despite use of LABAs and LAMAs combination. This combination is also, triple therapy is also now approved for asthma with a lower dose available for both asthma and COPD and a higher dose approved for just asthma.
The effects of corticosteroids by any route of administration are much less dramatic in patients with COPD when compared to patients with asthma. This may be because pulmonary inflammation is not prominent in COPD, or that the specific subpopulation of patients with COPD most likely to benefit from steroids has not yet been identified. That doesn't mean that you shouldn't use corticosteroids, you just aren't going to see as dramatic of effects. Although short-term use of oral steroids is effective for patients with acute exacerbations of COPD, long-term use is not recommended in patients with stable COPD. Patients who receive long-term oral corticosteroids can develop steroid myopathy, osteoporosis, hyperglycemia, as well as other complications such as pneumonia. Therefore, given the lack of efficacy and risk of side effects, long-term oral steroids are not recommended. Now, inhaled corticosteroids should be added to inhaled bronchodilators in patients with COPD with frequent exacerbations in an effort to improve outcomes. With inhaled products, adverse effects are typically limited to candidiasis and dysphonia. This can be minimized with patients rinsing their mouth after each use. With high doses and long-term use, patients can develop skin bruising. In other cases, cataracts and reduced bone mineral density have developed. However, patients taking these high doses of inhaled corticosteroids may also receive frequent bursts of oral steroids for acute exacerbations, and this may confound the actual risk of systemic adverse effects with inhaled corticosteroids. Studies have indicated a statistically and clinically significant increase in the diagnosis of pneumonia in patients receiving inhaled corticosteroids alone and in combination. But it was not shown in patients just receiving long-acting beta agonists alone. This risk was confirmed in a large meta-analysis of 18 randomized control trials and nearly 17,000 patients with COPD. Inhaled corticosteroids increase the risk of any pneumonia and serious pneumonia, but did not increase the risk of pneumonia-related mortality. Monotherapy with an inhaled corticosteroid should be avoided in COPD, but can be used in asthma. Monotherapy with a long-acting beta agonist appears to be safe in COPD, but not in asthma. An inhaled corticosteroid, alone or in combination, may be harmful for COPD due to increased risk of pneumonia. Combination therapy offers little advantage in reducing exacerbations of COPD and should be reserved for patients with severe COPD. Just a note on oral beta blockers. It's a medical myth that beta blockers are contraindicated in patients with COPD. In a Cochrane database, they concluded that there were no significant adverse respiratory effects with cardioselective beta blockers in patients with mild to moderate COPD. Therefore, patients taking non-selective beta blockers should be switched to cardioselective agents, such as atenolol, bisoprolol, or metoprolol. Since atenolol has a meta-analysis data suggesting a lack of benefit, the preferred beta blockers in this situation would probably be metoprolol or bisoprolol. Additional data suggests that beta blockers decrease mortality and exacerbations in patients with COPD, even in the absence of cardiovascular disease. Poor adherence with asthma medications is very common. It's estimated that 50 to 90% of adults and children do not take their inhaler medications as prescribed. Notice that both the unintentional and intentional contributory factors both contain cost. As I've mentioned earlier, inhalers are quite expensive. Here are some screening questions to ask. Do you find it easier to remember your medication in the morning or in the evening? Would you say you are taking it 3 days a week or less or more? Ask them to bring in their inhaler at every visit so you can review their inhaler technique. But also look at their prescription date, label date, and dose counter. Unfortunately, many of the labels are placed on the box for the inhaler rather than the inhaler itself, so making dates inaccessible. This is a synopsis on inhaler training. First, you must choose the appropriate inhaler. The patients must be educated with demonstration and return demonstration. On the next several slides, I will be going through the different types of inhalers, and there are links for YouTube videos, and I will post them below this spot on Blackboard so that you can access them off the slides. I am reviewing the most common inhalers on these slides, but not all of them. These are the steps for the use of the metered dose inhaler. Be sure to review the video and know the steps for each type of inhaler. A spacer is used for persons who may need to improve coordination between delivery of the medication from the inhaler and breathing it into the bronchial tubes. A spacer also reduces the amount of medication that settles in the mouth and throat, thus reducing the risk of thrush. A spacer is more often used for a child or older adult. And these are the steps for a metered dose inhaler with a spacer. Be sure to review the video. These are the steps for the use of a dry powder inhaler discus. Be sure to review the video. Here is the directions for the dry powder flexhaler. Again, be sure to watch the video.
The next two slides compare the metered dose inhaler, that's with and without a spacer, and the dry powder inhaler. So look these over. Here are the steps for a soft mist inhaler. Again, be sure to watch the videos.
Very few inhalers are generic. I believe that ProAir HFA and Ventolin HFA inhalers and others for albuterol and then Advair are now available generic, but no other inhalers are available. Use the name brand of the drug on the prescription only when it is the only form available. This is not an absolute rule, but can help you be more correct. For instance, with Spiriva, you can correctly order the HandiHaler or the Respimat much more easily. I don't think writing the prescription with the brand name matters as much with tablets or capsules. If generics are available, you should write the drug name as generic. So order the devices by the inhaler as the dispensed amount and not the number of actuations it contains. For refills, be careful. For rescue inhalers, if they are using them too frequently, you need to know this. If you give them 3 refills in which the prescription's good for a year, they have a total of 600 actuations to use. 600 divided by 12 months is actually 50 actuations or 25 rescue doses per month. This is dangerous to need this many rescues per month, and you as the prescriber might not know it. I would only give 1 refill on rescue inhalers at the most. For maintenance inhalers, it depends on how frequently you want to see them. So if you want to see them in 3 months and you give them extra refills, they won't come back. You have to balance this with trying to ensure that they are adherent and making it easier to refill. Newly diagnosed patients need to be seen more frequently, while those who are familiar with their disease and are stable can be seen every 6 to 12 months. Where to find the generic information? In Hippocrates, when you look up a drug such as tiotropium, the selection only gives you 2 brand names, Spiriva HandiHaler and Spiriva Respimat, so there is no generic. If you look up Spiriva and click on the HandiHaler, the generic that is listed below the brand name has no link. If you compare this to albuterol, you have several options. If you look up ProAir HFA, you can click on the generic name below the trade name, and it gives you other brand names, and at the bottom is the generic. Now, Lexicomp is what is listed for drugs under up to date. In Lexicomp, the generics and brands are listed under dosage forms for the US.
Thank you for your time and attention. I hope that you have learned something new about COPD and asthma and their treatment.